Now, there are some people who do a routine ligation of the thoracic duct to prevent chyle leak. Important point to remember is it does not completely prevent the chyle leak even after routine ligation. And this data is predominantly the pre-ICG era. So we need to actually now see in series where with the routine use of ICG and if someone is doing a prophylactic ligation, what is the post-op chyle leak? But it has been reported that even with prophylactic ligation thoracic duct, chyle leak have been reported, and there are various reasons. As the one is because of when you do actually the blind, the prophylactic ligation without ICG in the past is you ligate all the tissue between the esophagus and the aorta, and if there are some accessory ducts, you can have a leak despite that, or you can still have injury, especially below the ligature, or your clips can slip, and some attraction and at the stump area. So there are various reasons why leak can still happen after the ligation of the thoracic duct. So that's something new to keep in mind. The lastly, so if you have a chyle leak, so what you do, I think it is easy to suspect chyle leak once you have a high ICD output in the first 48 hours. Uh, then you need to suspect. The initial line of management is always, uh, at least we keep NPO because it is very difficult to strictly give a medium chain triglyceride diet. So better is keep NPO and put them on TPN. Give a trial of 48 hours. If there is no improvement, the improvement means if the volume remains more than 1 liter per day, or there is a reduction, but it remains high, that is less than 1 liter, but still high till day 5. So those are the indication for intervention. If there are facilities, you can try the thoracic duct embolization after lipidal lymphangiography in centers where there is good IR team. Otherwise, you need to go in and ligate. Uh, and the preferred approach is by thoracoscopy, go by the right VATS approach. But sometimes when the injury is much lower, especially in the hiatus, when you have a locally advanced G junction tumor, you have done a resection of the crest, then there is a possibility that thoracic can injure at that level. And in that scenario, you might have to go transabdominal, and then this is one of the such cases. Again, you can use ICG to locate. This is a transabdominal approach where you take a mass, you ligate the thoracic duct at the level of hiatus, especially when the injury is happening at that level. So the take-home message is the routine thoracic duct excision is not recommended to improve oncological outcomes in esophageal cancer, and the indication is more selective now. For the identification of the thoracic duct, inguinal node ICG lymphangiography is preferred, and whenever there is chyle leak, uh, be aggressive and intervene early to improve the outcomes. Thank you.